All right, we're going to get started. Thank you everyone for coming. This is the TGCT Day of Learning in Colorado. If you didn't realize you were in Colorado, welcome. And for those speaking, Dr. Clay, Dr. Wilky may not be in here, Dr. Maleddu, it is recording from the computer, not the mic. So talk to the computer ideally. And we will do our best to make sure it's recorded for anyone who couldn't come. So to go over the agenda, we'll start with my welcome. Hi, I'm Sydney Stern. You'll hear a few times my name. I'll go over TGCT 101, and then we will switch over to our lovely pathologist, Dr. Michael Clay, who is the first time we've ever had a pathologist. So please, they don't come out of the lab as often as I'd like. So I'm so happy to have him here, and he'll go over all of those questions you typically ask me that I don't always know. He will know. Then we will go over the preoperative treatments and surgical management with Dr. Nathan Donaldson, systemic therapies with Breelyn Wilky, as well as Dr. Alessandra Maleddu in the back. And then we will do a roundtable. We're going to switch some of the roundtable up a little bit with Dr. Maleddu, Steven Thorpe, who's also not here yet. And so we'll have a bunch of doctors. This is by far the most. So please thank them for their time. We will have a break for lunch, and then we will have a patient support group. There are people that are representing pharmaceutical companies and other industry members. For that support group, we will ask you to leave, and we'll just let patients talk. And then I'll give you closing remarks. So first, to introduce the speakers, Dr. Michael Clay will start. He's an associate professor who works as a leader in adult bone and soft tissue pathology. He's also the director of soft tissue pathology fellowship. He will also be able to introduce himself more thoroughly than what I can find on the internet. But he specializes in anatomical and molecular pathology. Nathan Donaldson, who you'll hear from, who's actually here, I see his face. He's an associate professor. He works at both Children's Hospital of Colorado and the University of Colorado here. He specializes in orthopedic oncology, and he treats musculoskeletal tumors like our disease. No shock, that's why he's here, and he is lovely. And Dr. Breelyn Wilky, she's the director of sarcoma medical oncology. She specializes in medical oncology. She treats bone and soft tissue sarcoma. Many of you have seen her. And if not, and if this is your first time, she is greatness. So you are in the midst of greatness. And I say it just because it makes her uncomfortable. A special thank you to Dr. Alessandra Maleddu. She is the reason I was able to put this together at times. So she spent a lot of time with us helping. She even picked me up at 7:30 in the morning. So amazing. She will also do some of the roundtable, and she's a medical oncologist here who specializes in the care of patients with soft tissue and bone sarcoma. So first, I'd like to thank the speakers. They are doing this out of their own kindness. When I ask them, they're not required by any means. So thank you guys for being here. The Life Raft group, as you've met Sarah Rothschild in the back, give a wave. She's the biggest supporter of us and my biggest supporter, I would say, and it's been love at first sight since, so some of this is only possible because she's involved. Principal investigators, clinical trials are why treatments develop, so I love to thank them. Physicians involved, the medical advisory board that continues to give me problems to solve, I guess is a good way to put it. Sponsors and donors, right? None of this it's all free for patients, and we love to keep it that way, but there is a cost associated, and that's all because people donate. Dr. Maleddu specifically for helping today. All of the drug companies and biologics, who's not a drug company, here today. So biologics, EMD Serono, Daiichi Sankyo, Synox, and Decipher. Both or all of them have contributed to the success of this event. The TGCT TDOL crew, as I call it, Betsy, wanna wave, Flancia, Alex, Carol, and Art, they all spent an enormous amount of time setting up and listening to me complain. So they deserve a special award. And patients and caretakers, it only matters because we're all here, right? So a special thank you for you guys taking your time out of your Saturday to be here. So back to the nitty gritty. So I'm going to give you guys a brief introduction of the disease, and then I'm going to have Dr. Clay give you a better version. So I get asked all the time, like, how did you do this? And so this is a great opportunity to talk about how great we are. So starting with our origin story, it started out as TGCT support. A lot of us have been in Facebook groups, right? We all started there. We asked questions on there. And so the Life Raft group, specifically Sarah, entered one of those Facebook groups. And she asked a question: would you change your diet for drugs to be more effective? And I was like, hold the phone. You don't decide that, right? There's drug approval process, there's bioavailability, there's all these fancy words we have, pharmacokineticist words that we use to describe why you would consume food. And so I gave a very technical answer, as some of you have experienced. And she was like, who is this? So we met. And from that moment, it was like we both had a shared mission. And so we started out with 2 webinars, both for giant cell tumor of the bone and tenosynovial giant cell tumor, because they're commonly misconstrued for each other. And it blew up. It was over 1,000 views. People loved it. And so I was like, cool, this is where I belong. So we made TGCT support in 2019. And where we are now, we have over 600 members in 6 different global support groups. We have a TGCT support France with Art here, Wave Art, who came from France. So we have people all over the world who have come here just to support the mission and trying to cause support for people. We have more than 1,000 patients in our patient registry, which is actually getting, you'll see later, is submitted like on Monday, data according to it. So you can actually scan that code and participate if you're interested. We have patients from 44 countries involved and all US 50 states. We have more than 200 patients that have participated in our mentorship program, where we partner patients with an expert patient to get involved. 3 TDALs, you are now in the 4th. 16 webinars with 3 planned in 2024 and 2 research projects in 5 years. Whoop, whoop, whoop. And so some tangible things we've done is we participated in this best clinical management practices, which is the first consensus guideline, we'll say. We kind of call it TGCT Bible, that you go to when you have a question or you want to know the way of treating it. And we took that and made it into a patient-friendly version in 3 languages as well. So we have, with the help of TGCT Support France, specifically Arthur, so give him a heads up for that one, in French, Spanish, and Italian. We also helped change the NCCN guidelines to include TGCT as part of the sarcoma guidelines and include treatments like Pexi, like imatinib, like nilotinib as part of the treatment paradigm and recognized by them. We also have a CTOS paper. Hopefully it will be an oral presentation and you guys will hear all about it soon. We find out August 15th, but we do science too. And then lastly, literally on Monday, we submit our first manuscript about the registry. So the data, the things that you do, your participation do matter. Please continue, because the only way it's successful is through this all. That's my spiel. Now to science. So tenosynovial giant cell tumor, or TGCT, is formerly known as PVNS, or pigmented villonodular synovitis. A lot of us were diagnosed with that nomenclature. It's a rare soft tissue tumor that arises from the joint, or the synovium, as we call it, or tissue surrounding tendon sheath, or the bursa, which is a fluid-filled sac. Prior to molecular drivers being discovered, TGCT was largely treated by orthopedics and sports medicine as a synovitis, or an inflammation of the lining. This is not news to many of you who were diagnosed as sports or by sports surgeons, but it was more treated as a rheumatological disease. But what we know is that TGCT is a benign neoplasm of unknown origin. So it can occur in the joint capsule, which is that, do I have a pointer? Maybe? Ooh, now I feel fancy. So it can happen in the capsule, that fluid-filled area. It can happen on the tissue that surrounds your tendon sheaths. And it can also occur in these as fluid-filled sacs that I talked about, which is called the bursa. And you'll hear more much better versions of that from the other doctors that you'll see today. A lot of the times I get asked, what's the difference between TGCT and sarcoma or cancer in general? They have some shared qualities and they have some very big differences, but they have enough shared qualities and that's why they're treated in cancer centers. So TGCT is considered slow growing. Everything's a spectrum, but it's on the slower side. It's locally aggressive. It rarely metastasizes, and it can put stress on bones, tissue, and joints. Whereas cancer is systemically aggressive, particularly sarcoma. It's capable of spreading to the lungs very commonly in other areas, and it's life-threatening. It can dissolve or invade healthy tissues. Some shared traits, though, are that there's different growth rates. Cancer can be low grade, which means it grows very slowly or has low risk of spreading in some ways, or it can be very aggressive, like a very high grade cancer, which immediately can spread or be very dangerous. It has no distinct borders for the diffuse type. It affects healthy tissue, and it's treated sometimes with systemic therapies. So I keep saying that it was previously called this, it's previously called that. In 2013, TGCT was taken by the World Health Organization and subdivided into two categories, diffuse and, I knew I had an animation for this. So it took PVNS, nodular synovitis, tenosynovitis, and giant cell tumor of the tendon sheath, and it made it one uniform disease. It was very confusing. You'd go to a doctor, you'd hear you have tenosynovitis or nodular tenosynovitis or any of these names, and then you go to someone else and they call it something else. And how do you ever find information if we don't use the same name? So there was an effort to consolidate the naming with two distinct subtypes, a localized form and a diffuse form. The localized form is known to be more very local. We call it like it's encapsulated. It has a fluid little sac. It's like a knapsack full of tumor. And if you just rip the knapsack out, and ideally you remove the tumor, but diffuse is more like gum in the carpet where it's really hard to find where it starts and where it stops. So it's hard to remove. So there's some inherent differences. Diffuse also occurs typically in larger joints. We'll talk about the predominance of certain joints. It does not have that distinct boundary. It's real in the carpet. It's typically or was previously considered larger, sometimes had multiple tumors, more aggressive with higher recurrence rates reflected. The nodular form or localized, it depends where you live sometimes, whether you'll heal nodular, it depends if you're a radiologist. So sometimes they'll use the words, they're synonymous for each other. Typically occurs in smaller joints with the fingers and digits being the most common. It has a distinct boundary, that little tumor knapsack. Previously, it was viewed as smaller, a single tumor, less aggressive with relatively considerably lower recurrence rates. We removed this larger versus smaller dynamic. I always get asked that, do you think it's a large tumor? And you're like, well, it depends the joint. There's so many references, right? It depends. So that was removed accordingly. So there's some inherent differences. Diffuse also occurs typically in larger joints. We'll talk about the predominance of certain joints. It does not have that distinct boundary. It's real in the carpet. It's typically or was previously considered larger, sometimes had multiple tumors, more aggressive with higher recurrence rates reflected. The nodular form or localized, it depends where you live sometimes, whether you'll heal nodular, it depends if you're a radiologist. So sometimes they'll use the words, they're synonymous for each other. Typically occurs in smaller joints with the fingers and digits being the most common. It has a distinct boundary, that little tumor knapsack. Previously, it was viewed as smaller, a single tumor, less aggressive with relatively considerably lower recurrence rates. We removed this larger versus smaller dynamic. I always get asked that, do you think it's a large tumor? And you're like, well, it depends the joint. There's so many references, right? It depends. So that was removed accordingly. And while many of us in this room have diffuse disease, overwhelmingly TGCT occurs as the localized form, the form that's easier treated by surgery, where majority of patients have 39 people per million get diagnosed with the localized form in a period of time, and then the diffuse form, it's 4 per million. So I always hear people say, I'm 1 in a million. You're not. You're 43 people per million to be diagnosed. It is not a life-threatening disease, which means all of us live with this for longer. So this is just your risk of being diagnosed. And so I try and explain the difference between an incidence and a prevalence. An incidence measures the new cases in a specific period. So who's at risk of actually being diagnosed versus the proportion of patients that actually have it in a population. So who's living with it? More people are living with it. In fact, 44 people per 100,000 people have the nodular localized form. whereas 11 people per 100,000. So we're rare, but we're not that rare, I guess is the point, right? We're all here. So if it was that rare and diseases that are life-threatening tend to be smaller prevalence because people die. But since we are healthy generally, people can live a long time with this disease. So TGCT can arise in the same cell tissue regardless of the location, and it's still considered TGCT. It can be in the joints or the capsule, the tendon sheath, the bursa, and around 80 to 85% of TGCT, particularly diffuse, happens in the knee. So if you look at like how thick the bars are here, the knee being the most common, hip being second, ankle being third, toes, fingers, shoulders being less common for the diffuse form. And when we talk about like diffuse versus localized, there is a prevalence difference in what joint it affects. So the localized form typically affects the fingers and toes more than the knee being less, and then the diffuse form is more knee, ankle, hip, as you heard. So I keep saying, why did the naming change? Not only was it inconsistent when you went to the doctor, but it truly did not reflect the disease biology. Pigmented villonodular synovitis has the word synovitis in it. It chalks it up to inflammation, a rheumatological issue, an inflammatory response, which it is not. So TGCT is unresponsive to steroids, unlike rheumatological diseases. It's not a simple inflammation. It has this neoplastic biology, which you'll hear quite a bit. It means it can grow on itself or it divides. And it should be treated by multidisciplinary care at a cancer center. And someone that I admire used this reference, and I don't even know who Sting is. So an Englishman in New York is still an Englishman. So regardless of the location of disease, it's the same. So it sounds like a lot of people here know who Sting is. So hopefully that resonates. So TGCT occurs sporadically. It's random. It is not passed down nor inherited. You will not give it to your children and vice versa. The prevalence among men and women is fairly similar. Females slightly have a higher preponderance of the disease, and the onset is generally young individuals with a slight younger shift when you have diffuse disease. It's completely random. So that also means that there's no environmental, geographical, occupational, dietary, or lifestyle causes of the disease. And if there were a single risk factor, we would know. So it's random, it's likely multifaceted. So I told you a lot of things we don't know, which seems kind of glib, right? So I'm going to tell you what we do know. We know what TGCT is made of. We know where it comes from. So TGCT comes from this lineage called mesenchymal. Sometimes it's called mesenchymal. You'll have to like listen to how the doctors say it because you'll just hear differences in that. And I can't actually figure it out which one it's supposed to be, so I'll have them correct me. But that means it's a soft tissue tumor, essentially. There's other tissues that are part of the same lineage, adipose tissue, which is a fancy word for fat, bone, tendon, marrow, which is in bone, cartilage, and muscle. They all come from the same lineage. They're connective tissues. And so when I say lineage, it's really as simple as a family tree. So mesenchymal cells start at the bottom, and then the tree of maturation occurs, and they can become TGCT, muscle cells, fat, bone, etc. So it's all part of the same family. And so some of the cell types involved in the process is a synovicyte, which is responsible for the production of the synovial fluid component, and that blood synovial fluid exchange. Sometimes people have extremely bloody joints, and that's even for an ER factor that people are like, oh, okay, you must have this disease because you have a bloody joint. And those are part of that cell type is part of that. Fibroblasts and stromal tumors, these are a type of connective tissue, and osteoclasts like multinucleated cells. Cells have single rounded center. They look like a giant eyeball, and some of them have multiple rounded centers. And so osteoclast-like cells dissolve bone. And so in some patients, you can see some damage from these osteoclast-like multinucleated cells. So TGCT is not just this connective tissue. It also recruits white blood cells. Similar to that like fancy family tree I showed you, white blood cells have a family tree too. And so in my little corner over there, you see that monocytes, macrophages, and all of these other fancy names for cells are all part of the same lineage, and they get recruited, particularly monocytes and macrophages, to the TGCT. And sometimes they're latent, is what we call them, with hemosiderin, which is an iron storage, which causes that rusty color you guys are all used to, right? So some of these cells that we associate with the disease aren't actually the disease. They're brought in to the disease. So I can't talk about any of this without biology. I love biology, right? Like it seems like with this audience, I would have the perfect opportunity. So just some basics as we go through talks that you'll continue to see, that these are kind of where it starts. So a gene and a protein, genes are the construction or genetic blueprint. We have many of them, and they're like a library of books, you'll say. And so the human genome encodes more than 30,000 different proteins, and different cells make different proteins. They have jobs, right? So some are construction workers, and that's what their job is. And some maybe are to move oxygen around your body, right? They all have different functions. And so muscle cells may make actin and myosin, which causes contraction when you move. Or red blood cells make hemoglobin move around your body. And that's why you are all here today, is because you have hemoglobin. And neurons make ion channels, which allow you to think and process things I'm saying. And so genes are squished up into chromosomes. So they're all wrapped up. And we call this figure here, the DNA, RNA to protein, which you may have learned in high school at some point, is the central dogma. So you read a book, then the librarian will say, takes what's in the book and delivers it to the person that makes whatever's in the book, like an instruction manual. So I actually use construction a lot as my examples. So you have the genetic blueprint, and then the contractor comes in, and then the construction crew actually makes it. And the final product is protein, which has a function. Proteins are made up of long sequences of what we call amino acids. There's alanine, cysteine, all of these. Phenylalanine, if you look at any soda bottle, you'll see on the back, it says do not consume if you have a specific disease where you can't process phenylalanine. And so you'll see it actually in every day if you start looking for it. But proteins are sequences of this, and how they fold and how they function is directly related to both the sequence and how they fold up together. Why does this all matter? Is because there's a driver of TGCT, which starts on a gene and ends in a protein, right? So I'm giving you guys some background. So TGCT has something called a translocation. If you look at my little cute figure in B, you have chromosome 1 and chromosome 2 here. All of these have genes pushed up together. And what happens with TGCT is a translocation where chromosome 1 has an abnormal break, and that attaches to chromosome 2 as a separate chromosome. That causes the colony stimulating factor 1 gene to translocate from one position to the next position, fuse to it, and then therefore it overproduces this protein that's associated with the growth of our disease, or CSF1. The presence of this abnormality is estimated in 2 to 16% of cells, so it's not everywhere. It's actually only in a few TGCT cells. So if you were to look in your body, you're not going to find it other places. You're going to find it in your TGCT, and it's a very minor amount. So again, the blueprint gets chopped up, and that causes changes in what's built. And so this is actually, I love protein structures. I know everyone's like, this is, I see Betsy's face, like I'm over the protein structures. But this is what CSF actually looks like. We can see what it folds into, and it's super long. It's 552 amino acids. And why does that matter? Is because CSF binds to the receptor. We are not clever in science whatsoever. We have a target, we have what it hits, and we call it the same name with an R. So you have CSF, which is what's floating around, and then you have the receptor is what catches it. So if we use a baseball analogy, CSF is the baseball mitt is the CSF1 receptor. So not very clever in the naming, but CSF1 hits their receptor, and that internalizes a signal into TGCT or the cells itself, which lead to a response that we associate with swelling, pain, and tumor growth. So TGCT uses this signal for growth. It's a protein that stimulates the multiplication of these pro-inflammatory cells, some of these immune cells that I was just talking about, and they exchange it allegedly. There's some contradictory information about how much TGCT actually has this receptor, so there's still a lot to learn. But essentially what it does is it says grow. That's what it boils down to. And so when we block that, we seem to have a drug effect that you guys, some of you are actually on and experiencing. And so CSF1 is part of a really big family. I love my family trees. Science does too. We just make them look really complicated. So on the left here, this is a family tree of protein. It's called the human tyrosine kinase family. You have CSF1 here, you have just a relative here, and then you have ABL1 here, or ABL. So I'm not really pointing out the importance of necessarily those, but that they're interconnected and related. And so some of the drugs you've seen, like imatinib, which you'll hear about from some of the amazing medical oncologists you have here, actually are known to block those because they block relatives, right? So you share features, you look similar, maybe you have similar hair color, maybe there's other features that are similar because you're in the same tree. And so I will let the very amazing doctors go through more about targeting that pathway, but hopefully that gave you a starting point to understand what we'll talk about next. And I have a phone, I think I do have time for questions. Woo! So if there's any questions for anyone who's